Start. We are live.
Hello, good evening, everyone. It's a great pleasure to welcome you all for this exciting webinar in the management of renal cell carcinoma in new millennium. Excellent weather. We carry the greetings from the Pink City, and it's a pleasure to welcome and invite Dr. Deepak Gupta, sir. Dr. Deepak Gupta is a senior consultant in the Department of Medical Oncology at prestigious Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. Good evening, Dr. Deepak Gupta, sir. Welcome for the session, and we request you to take the proceedings further with your welcome and introduction. Once again, good evening and welcome, sir. Over to you.
Thank you, Tarunji. Very good evening to everyone. I welcome you all to this meeting on renal cell carcinoma today. As you all know, March is Kidney Cancer Awareness Month also. So for last, I think more than a decade, for 10 years or more, we used 1 or 2 TKI in the treatment of metastatic RCC. But now for last 4 or 5 years, we have many drugs, newer drugs, IO drugs, and newer TKIs also available in various combinations or single agent in first line or second line. So it's a complex scenario now. So what to choose, what not to choose, what to use in first line, what to use in second line. There are multiple, many questions which sometimes are difficult to answer. So we have planned this meeting to answer some of those questions. So without wasting further time, I will move on to our main session. So our first session is by Dr. Asim Samar. He is consultant medical oncology in Bhagwan Mahavir Cancer Hospital. Is my colleague, and he will be speaking on translational medicine and biomarker relevance in metastatic RCC. Over to you, Dr. Asim.
Thank you, boss. And at outrightly and outset, I would like to thank Dr. Deepak Gupta, sir, and the organizers for this meeting. Can I share my screen? Earlier, yes.
Yes, sir. You can share your slides.
Okay. Just wait, I will open and then.
Asim sir, आप शेयर कर रहे हैं स्लाइड्स या हमें करनी है?
नहीं, मैं ही करता हूँ स्लाइड.
अच्छा.
This is, I guess it will move. Yeah.
Yes, sir. We can see the slides. आप screen slide share mode पे कर लें. Screen is visible, sir.
Okay, so it is moving now. Slides are moving or not?
No, sir. आपको इसको नीचे उस पे ना आप वो slide show mode पे कीजिए.
I have done that slideshow mode. In my computer it is okay. Actually the problem.
Slides move हो रही हैं, but not in slideshow.
वही हर बार हो जाता है सर के slideshow पे.
बस आप अब यहाँ पे क्लिक कीजिए. आपने बिल्कुल सही जगह क्लिक किया है. अब क्लिक कीजिए उस पॉइंट पे जहाँ आपने रखा है ना कर्सर.
ये हाँ.
नहीं कि वो मेरे में तो हो रहा है. It is moving in my computer, but it's not in your.
नहीं, ऐसा नहीं होगा. आप इसको सर दोबारा से आ जाइए. अब it will take a minute. आप स्टॉप करें और दोबारा से आए. कई बार हैंग हो जाता है. स्टॉप द स्लाइड. अगेन आई एम श्योर कि आपकी स्लाइड्स ओपन है. जस्ट डू अ शेयर सर अगेन. इट विल टेक अ मिनट.
Yeah, but we need is Microsoft Office, I guess इसमें करना पड़ता है. This is the share button. Right. Is it moving now? No.
No, sir. So can I share your slide?
You can share that. Huh?
Yeah, sure.
But generally it happens. So you share my presentation, which I have mailed you, right? Because there was very lengthy presentation.
Yes, sir. Yes, sir.
I have only 25 slides.
So slides आपके सामने हैं. You just have to say slide number, next slide. That's it. Please start, sir. Please.
Okay. So thank you, Dr. Deepak Gupta, sir. And thanks, Mr. Tarun, to organize this meeting. So we'll have discussion in this particular topic, relevance of biomarkers in RCC. So please move slide. Yeah. So RCC, renal cell cancer, constitute about 3 to 4% of all cancer globally, and it's a very heterogeneous disease. Though it's look like simple renal cell cancer, but it has a various histological patterns, and nowadays there are some molecular changes also discovered in the larger labs. So it is very heterogeneous disease, and the results are also very heterogeneous. Diverse histology, histomorphology, new entities being added, difficult in correct diagnosis, and we should have a very good pathological lab, histopathology lab, and molecular lab for diagnosis of correct pattern of the RCC. Very varied biological behavior, several clinical types and lab-based methods are there, and there are some risk modelers and dubious performance C index. Means like the observational difficulties are also there of the pathologist, and oncogenic addiction also discovered. Sometimes the RCC may be driven by the angiogenesis module, sometimes it is immunogenic inhibition, and sometimes it's metabolic also. Some enzyme deficiencies also discovered in this RCC. So can these be used as a targeting therapy? Next. So RCC, are there any biomarker that can improve the diagnosis? Yes, there are some. And can the performance of clinical or routine lab risk based risk models be strengthened by the addition of the molecular biomarkers? Yes, the progress has happened many parts of the world, and now they are from the bench to bedside. And can biomarker help in selection of the therapy? Yes, we will see in this discussion. So next. So this is the ladder pattern where we move from this pattern to this pattern. So in 1993 to 2001, the major focus of the renal cell cancer histology and the treatment was VHL, loss of function mutations. So it was the major discovery happened in 1993, and then the treatment revolved around this VHL loss of function mutation. In 2001 and 2013, this 10 to 13 years, this was the additional genetic alteration discovered in the RCC. You can see like 3P loss of heterozygosity, VHL 8Q loss of heterozygosity, then TCEB gene mutations, PBRM nowadays is very important, BAP1 and SET2. So, and now 2016, WHO has given the molecular classification of the RCC, and you can just move. Yeah. So RCC clearly divided nowadays in the two patterns: clear cell RCC 75% cases, and non-clear cell RCC constitute about the 25%. In non-clear cell RCC, we divide into the major part or major chunks of papillary RCC, papillary non-clear cell RCC. It is of 4 variant: type 1, type 2, HPC, and oncocytic genes. So it is of 4 types. Chromophobe RCC constitute 5% of non-clear cell RCC, and others are maybe the various mutation related: folliculin gene loss, SDS deficiency, succinate dehydrogenase deficiency, fumarate hydrogenase deficiency, and micro translocation deficiencies, TCB1 and ALK rearrange RCC. So usually we get to know like ALK rearrange are majorly responsible for the adenocarcinoma of lung. In some part, some settings of the RCC, ALK rearrangement is also discovered, and they are responding to the ALK directed therapies, maybe crizotinib and alectinib. Next. So this is the thing they have correlated, like this folliculin gene loss and SDS deficiency are related with the chromophobe RCC, and fumarate hydrogenase deficiency and micro TF deficiencies are seen in 2 types: type 2 papillary, which makes it very aggressive, and here is clear cell RCC in some pattern, and there are 2 mutations which may be found in the clear cell RCC also. Next. So again, 2012 to 2018, what happened with this molecular genomics? RCC, even with the same morphology, are different disease, evolving through different molecular pathways, different genetic and epigenetic alterations. So any alteration happens in the genomic levels, which gives the different pattern of the disease spread, different prognosis, different response to the therapies, and from which therapy it will respond. it is very difficult to say. In 2016 or 19, suddenly everything goes in favor of the immunogenicity of the tumor. Tumor immunity and microenvironment was the major focus of the scientists, and they discovered in and out immunotherapies. Genomics correlate immunity, genetic alteration to redefine response to immune checkpoint inhibitors. And this was the era of these immunotherapies, and we are using left and right. Then 2020, this biomarkers, they discovered some biomarkers, which is what many are useful, but none is fully validated because the data are very, very scarce. And you can see like seldom they are used, but in the reference labs and reference hospitals, like MD Anderson and all that, they do the genomic atlas testing and all that. And if they found some targetable mutation or some enzyme deficiencies, they usually try to overcome with this newer drugs. Next. So are there biomarkers that can improve diagnosis? Yes. Can the performance of clinical and routine lab-based risk model be made more robust by addition of the molecular biomarkers? It should be, but not yet they have made. And can biomarkers help in selection of therapy? Yes, we will see later. Next. Next. There are some example of that. So this is the fumarate dehydrogenase deficiencies of RCC. So this tumor morphologically or grossing, they looks very similar. This is the papillary pattern of the RCC, and the cells nucleus looks very, very aggressive. So there is no role of observation, and early metastasis to the bone happens in this particular variety because it's very aggressive, and they will respond well to a specific combination of therapy of bevacizumab or erlotinib. And you will be surprised, the response rate is more than 60 to 80% if you target this particular variety with this particular combination. If you use bevacizumab or erlotinib in the renal cell cancer, the clear cell cancer, nowadays we will feel like it's a very inferior regimen, but in particular setting it is very effective, and it is the only effective regimen. So finding this fumarate dehydrogenase deficiency is very, very important if you can find out. And next, so this is the example of how molecular testing is going on. Next, succinate dehydrogenase B deficiency, deficient RCC. So there are multiple small tumors, limited aggressiveness. They are not very aggressive, rarely metastasize, and diagnosis identifying the mutation carrier in the families because it can run into the family. And this is micro TF translocation. There is some new variety mentioned in the WHO classification nowadays. They're known as translocation RCC. Translocation renal cell cancer. So confirmed translocation by break apart FISH probes of this is of three types: TFEB, TFE3, and TFE amplification. So this some TFE expressing RCC may be ELK rearranged, and we know like we have some good drugs against the ELK rearrangement, and this is the this rearrangement should be checked out by the FISH only. Next. So there is one next good paper presented in the, I guess, JCO. Previous one, please. So they have shown if you have find out the ELK rearrangement pattern and you give this alectinib, there is a wonderful response in the RCC also. Next. But you need to first suspect and then confirm with the FISH. So type of papillary RCC type 1 and type 2. Scroll down, please. Next. And this is the papillary RCC NOS and oncocytic papillary renal cell carcinoma. So we might think like it is very difficult to diagnose histologically, but what happens is nowadays some ISC patterns are there by which we can differentiate type 1, type 2, and the other papillary carcinoma. So why it is important is you can see like the survival curve is very different in the all 4 types. Type 2 has a very grave prognosis. And this oncocytic papillary renal cell carcinoma has a very, very good prognosis. Almost 5 years survival is 100%. And type 1 is in between, and this NOS is little bit less than the type 1 papillary RCC. So defining the histological pattern based on the ISC is very, very important. We will see in the next slide. Next, please. So this is the slide which can predict, which can show you the how histology and ISC immunohistochemistry is very important. Papillary RCC type 1, papillary RCC type 2. NOS pattern and the oncocytic pattern. So there they have mentioned on the basis of the three RCC, three ISC pattern. This is the ABC C2, GATA3, and the CA9. These three are the ISC markers by which you can differentiate between the all four types. If they are negative, then it is NOS, but pattern is papillary. Papillaries are the projections, and their different combinations are there by which you can differentiate between the all four types of papillary carcinoma of the RCC. Next. So message is genomic ISC based on newly recognized biomarkers can establish or redefine diagnosis in 5 to 10% cases of the RCC. Inherited RCC confirmed by appropriate germline testing, and there may be mutation carriers in the family members, like we have said, like SDS deficiencies. Papillary RCC can be better diagnosed into prognostically significant categories using the combination of the ABCC2, CA9, and GATA3 ISC markers. Next. Next, please. Yeah. So what is the putative role of biomarker in prognosis? You in the basis of the biomarkers, we can divide RCC into the clear cell and papillary RCC. Non-clear cell, other variant other than papillary RCC are very, very rare. So clear cell RCC is VHL inactivation type and role of the other additional gene. Here we can see like papillary RCC on the molecular basis, it is identifying CAPG island methylation phenotype, CIMP RCC, or profiling late 7 family of the microRNAs. Next. Next, please. Yes. So this is the epigenetic mutation theory. Number of first hit in clear cell RCC and cancer specific survival in this particular model Kaplan-Meier curve. You can see like if patient has a wild type VHL, they have the inferior prognosis, and if patient has a inactivation of the VHL, they have the good prognosis, and otherwise activated mutations are the intermediate prognosis. So finding out them is not difficult nowadays, and we should define the mutation of the VHL gene. Next. So this is again same statement of the other mutations also. VHL inactivation, if you find in cancer, like the total cancer genome atlas, so tumor cancer genome atlas, VHL inactivation 52% patient will have, RCC patient will have this VHL, PB, RM1 30%, BAF1 10%, SETD2 12%, and TP50 2.2%. Next. Next, please. Yes. So prognostic workup and message in clear cell RCC, BAF1 has a very bad prognosis, localized disease, whether it is localized or metastatic, patient will fare very worse. TP53 bad, they are the bad mutation in each and every cancer, and we don't have any targeted drug against it, and they generally find out in the metastatic state, and if not, then also they will very early they will be metastasized. PB RM1 has a good prognosis, at least in the metastatic disease. In papillary RCC, there is absence of immunostaining for CDKN2A, P16, and FH fumarate hydrogenase identifies a subset of the PRC with the CIMP appealing prognosis, because if they are both are negative, then they have a good prognosis. Expression of the late 7 family of the microRNA can separate papillary RCC C1 from papillary RCC CC2. This is RCC2 means this papillary type 2 RCC has a very bad prognosis, but if this particular mRNA is present by DNA PCR, RNA PCR, you can say like it is a very good prognostic sign. Next, please.
Sir, request if you can conclude, sir.
Yes, I have 1 or 2 more slides. So this is the recent NCCN guideline where you can see this is the based on MSKCC criteria, IMDC criteria. So favorable and poor risk. Nowadays we are using in and out accidental pembrolizumab. This has 22 version has some other modifications also. So it is an older one. Next, please. Yeah, and predictive biomarkers for the VEGF targeted therapies. Next. The immune checkpoint inhibitors have transformed the treatment of clear cell RCC, but a subset respond the need for the predictive biomarker. Which subset will respond, we don't know. Conventional biomarker for ICB largely irrelevant in the clear cell RCC. Response in the clear cell RCC is not dependent on the tumor mutation burden, and it is not dependent on the neoantigens also. and this is TIB also does not correlate with the response. So there should be we should find out the other mutation, other markers, biomarkers also to predict correctly the response. Next, please. Yeah, you can move that side. Next. Yeah. So around 30 to 40% patient have alteration in the MET pathway. Trisomy 7 MET, geoff mutations, MET amplification, ligand of the MET, hepatocyte growth factor amplification, and MET inhibitor is a natural choice. Phase 3 severe data of comparing savolitinib against sunitinib shown no difference between the median PFS and has been terminated. Other effort to use MET inhibitor unsuccessful. SWOG 1500 phase 2 trial comparing sunitinib, savolitinib, cabozantinib, and crizotinib is active and result is awaited, but the interim analysis cabozantinib has taken the lead. Next, please. So this is the, I guess, last slide. PBRM inactivation in the clear cell RCC predict response to VEGF TKIs and immune checkpoint blockade, inversely related to the presence of the T effector cell and the deletion 9p23. ICB and VEGF targeted therapies, T effector high and angiogenesis low expressor benefits with this VEGF targeted therapy. KDM5C is a strong predictive marker for prolonged benefit from the sunitinib. Despite MET alteration being common, not been found actionable so far, unlike NSCLC, but nowadays they are saying cabozantinib is useful. It may be useful to test the PBRM, BAF1, SET2, KDM5C, and TP53 in the clear cell RCC for prognostication and therapy selections. None of these biomarker has prospective validation to recommend its use. Next. Thank you. Thank you, organizers. I have overshoot with the time. Thank you.
Thank you, Dr. Asim, for providing this meaningful insight on biomarkers in RCC, which is less known topic, and we have very little knowledge about that. Although most of these things are still, I think, experimental or not in clinical practice. So maybe in near future we may use more of biomarkers in these RCCs.
Yeah, but
thank you very much, and please, yeah.
Yeah, I learned too much about preparing this presentation. Most of the concept I have revised or gained first time in the life. So it's good to have some tough topics also. Thank you.
Yeah.
Anyways.
So thank you very much, and please stay with us for the remaining sessions.
Yes.
Thank you. So our next session is by Dr. Rajat Bajaj, who is a consultant in medical oncology at Fortis Hospital, Noida. He will be speaking on decade of experience with using TKI in first line metastatic RCC. Welcome you, Dr. Rajat. Over to you.
Good evening, everyone. Am I audible?
Yeah.
Okay. So I think Mr. Mathur is controlling the slides. I thank the organizers for having me here, and Dr. Deepak especially. The topic that has been given to me in the next 15 minutes is a decade of experience with using TKIs in first-line metastatic RCC. The first time that I saw this topic, I thought it's a little different because nowadays, the first-line metastatic RCC, the talk is only about IO and IO-based combinations. So is it relevant for us to discuss TKIs? I think certainly yes, and this is what I'll talk about in the next 15 minutes. Next slide, please. So a decade of experience is an important phrase for me. Next slide. And the reason for that is that, of course, we do keep talking about the new that comes up, but then we should always keep the old, because the old may not be silver, it may actually be gold. And next slide. If you talk about the word experience, experience is something which teaches us a lot of things in life. And experience is something that just cannot be replaced. And next slide. This is what we really learned yesterday when this man who had all the experience, next slide, told us that I am here to stay for another, maybe not 5, but 10 years. Next slide, please. So next slide. Talking about the RCC in India, there are approximately more than 15,000 new cases and unfortunately 10,000 deaths from RCC new year. 1/3 of the patients who are diagnosed for the first time, they actually have got advanced or metastatic disease at presentation. And very naturally, we all agree that these advanced and metastatic cases actually have a poor survival, whatever we may do. Next slide. That is why it is important that we should actually have good armamentarium in us as far as the treatment of metastatic RCC is concerned. Also, there's an analogy that we can draw between the COVID waves that we had in this analogy actually is that we've had 3 waves till now in the last 2.5 years. Next slide. So in the initial part of treatment, in 2005 we had the TKIs as the RCC treatment most commonly. Then we had the IO agents in 2015, and the current wave for the RCC treatment actually is, next slide, IO plus TKI, which started just like 3 years back, and it has been like a tsunami where IO plus TKI have taken over in the first line metastatic RCC treatment. Next slide. But having said that, very important for us to understand that this is the evolving frontline therapy in metastatic RCC from the last 20 years or so, and we see that initially the times of interferon alpha and interleukin 2, the TKIs started to be developed for this management, for the management of this disease, from sorafenib to sunitinib in the early 2000s, to pazopanib in 2009, to exitinib and cabozantinib initially in the second line, and then eventually coming to the first line, especially cabozantinib. Next slide. So this is the TKIs that I'm going to focus upon, especially sunitinib, pazopanib, and cabozantinib, because I've been told to restrict myself to the first line management of metastatic RCC. Next slide. So as we all agree that IMDC or the Henk criteria is the way to go in a patient who's first time diagnosed with metastatic RCC nowadays. This is the criteria in front of us. We all are aware of these criteria. So with a maximum of 6 that the score can be, we can talk about dividing our patients and segregating them into the risk stratification being either favorable, intermediate, or poor. If we talk about favorable, then the score has to be strictly 0. Intermediate is a score of either 1 or 2, and poor risk is 3 or more than 3. This is how we really select our treatment. So IMDC risk stratification has certainly become predictive. Of course, it is prognostic, but it has become predictive at least in the last 3 to 4 years now. Next slide. And also, very importantly, this this slide on the screen right now tells us that if we talk about its prognostication, then favorable has got maximum overall survival as compared to intermediate, which comes the second, with the poor risk stratification patients having the least survival out of these 3 risk stratification domains. Next slide. Talking about how sunitinib came into being. So sunitinib versus interferon alpha in metastatic RCC was the registration trial of sunitinib, which was published in NEJM in 2004 by Motzer et al. And next slide. This trial actually told us and showed that sunitinib was better than interferon alpha in terms of progression-free survival, which was the primary endpoint of this study. The sunitinib arm had a PFS of about 8.5 months, whereas the interferon alpha arm had a PFS of 5 months, with a delta of 3.5 at that time was certainly enough for the US FDA to approve sunitinib for the treatment of first-line metastatic renal cell carcinoma. From 2004 to probably a decade, that is till 2014, sunitinib has ruled the roost as far as first-line metastatic RCC is concerned. The dose of sunitinib and the schedule of sunitinib, which was initially in the beginning 4 weeks on and a 2-week off, all of us know that this schedule nowadays is not very widely followed, and the dose now which is followed is a 50 milligram once a day. But the schedule is 2 weeks on and 1 week off. In the phase 2 trial and many retrospective studies, it has been seen that this schedule probably is better tolerated and has got less of mucositis and less of hand-foot syndrome as compared to the 4 weeks on and 2 weeks off schedule. Next slide. So, we've discussed that sunitinib is has been a major game changer in first-line metastatic RCC. But in the last 3 to 4 years, like I mentioned in my opening slides, there has been a little so-called threat to sunitinib and its supremacy in first-line metastatic RCC by coming in of the third wave of the so-called RCC treatment agents, which is the IO plus TKI, and there are at least 4 to 5 trials which have recommended that as far as the control arm of sunitinib is concerned, we have the experimental arm of IO plus TKI, be it with pembrolizumab combination with a TKI or nivolumab for that matter, which has shown that the PFS as well as the OS in some of the trials is better than sunitinib. Agreed, that point very well taken. But then, does it really mean that sunitinib has got no value at all? Probably no. This is not the right thing to say. So this is January 2020, where the journal called The Oncologist has published this article, which is the real RCC according to the IMDC criteria. Next slide. So what they actually did is that their objective was to address this gap in knowledge about the real world assessment of metastatic RCC patients who were given first line sunitinib and according to the IMDC prognostic risk grouping. Next slide. And they also wanted to assess whether there is any heterogeneity between this group called the intermediate risk group, which is a very interesting thing that they did. This is the baseline characteristics of all the patients that they had taken. So a little busy slide this, but one can see that there were at least 1,700 patients that they had taken, and nearly 1/3 of them each were there in the favorable, intermediate, and the poor risk category. Next slide. So what they all wanted to see is that they wanted to see the time to treatment discontinuation. They wanted to see the overall survival, and they wanted to see the response rates according to the various IMDC criteria. So the time to treatment discontinuation was the maximum with or the longest with favorable risk and the least with the poor risk, and intermediate risk was in between the two, as the Kaplan-Meier curves here can very well suggest. Next slide. And if you look at the overall survival, the overall survival also was the longest with the good risk as compared to the least with the poor risk. If you look at the response rates were touching about 40% in the favorable risk, whereas it was only a meager 20% in the poor risk. Next slide. This is the overall survival I was talking about, and one can see that the overall survival in the favorable risk is touching 52 months, whereas it is the poor risk, it is just a paltry 9.8 months. So certainly IMDC risk stratification does play a role, and very importantly, the important message is that if you're talking about favorable risk, sunitinib still is the way to go, and it can easily be a player where one can lay its confidence upon, even in the era where we're talking about IO plus TKI. Next slide. These are the next slide is telling us about the heterogeneity between the intermediate risk grouping in this particular article, where they said that the intermediate risk grouping can be divided into a 1 risk factor or a 2 risk factor, and a 1 risk and a 2 risk factor, if they at all they do, this dichotomy becomes even more if you look at the Kaplan-Meier curves, where the 1 risk factor intermediate risk grouping is doing almost similar to the favorable risk. If one can see, this is the Kaplan-Meier curve, where we see that almost favorable is what one can see. So this is something which is very important. And if it is 2 risk factor, then it becomes akin to the poor risk stratification.
So we can't hear you. Sir, we can't hear you. Hello. Hello, Dr. Rajat, sir. Hello.
Yeah, sir, might be some internet issue from his side. Yeah, he left.
Okay. Hello, Dr. Rajat, sir. Can you join again, please?
Is not connected, Tarunji. How he will respond to your query?
And then no problem, sir. He will join. He will join.
I think he must be joining again.
Yes, sir. Yes, sir. Yes. सर मुझे 1 मिनट दीजिए. I will just call Dr. Rajat.
Yeah, वो मैं भी यही करता, एक बार फोन कर लीजिए.
Right.
Hello, yes, am I audible?
Yeah.
Yeah.
Sorry,
so,
there was a connection error suddenly and I couldn't really help it. So I think we should move ahead. Next slide, please. So the real world assessment of the clinical outcomes of first line sunitinib according to this trial told us that in patients who are having a favorable IMDC risk grouping, they significantly had a higher OS, time to treatment discontinuation and response rates compared to patients with intermediate or poor risk. With a favorable risk, patients having a OS of up to 52 months and a CR rates of 6%, which was quite overwhelming. And in patients who had an intermediate risk with one risk stratification, the OS touched 35 months, which is almost similar to the good risk stratification. So sunitinib certainly can be used in patients who have a favorable risk and can also be used in patients who have an intermediate risk with one risk factor. Next slide, please. Continuing with what we've discussed, that is the real world scenario with the use of sunitinib. This is the Adonis trial, which was published in March 2020 in the genitourinary cancer. And this again is a real world experience of sunitinib in treatment of metastatic RCC. The clinical outcomes according to the risk stratification. Next slide. So these patients who were given sunitinib were all patients where the first line use of sunitinib was done. And what they actually needed to do and what the objective of this patient was that they evaluated the use of sunitinib according to the IMDC and the MSKCC risk stratification. An analysis of sunitinib efficacy was performed in a subset of patients identified as the risk factor set. That means that individuals where the risk factor data was available. And again, the heterogeneity between the intermediate risk grouping was kind of sought after. Next slide, please. So this is the trial methodology where from 2014 to 2019, the patient enrollment was done. And the last was May 2019. Next slide. And the outcome which they wanted to see was the efficacy, PFS and OS and the safety. Next slide. So it is very interesting that when they looked at the effectiveness of sunitinib by virtue of progression-free survival and again by the risk stratification by IMDC, they found out that the favorable risk group did the maximum, the best, with the PFS of nearly touching 24 months, with whereas the poor risk was only 5 months. The intermediate risk, the PFS stood at about 12 months. As we can see, the Kaplan-Meier curves, they are separating in all the three subgroups. Next slide. If you look at the overall survival, same was the picture. OS was the best with favorable risk and the least with the poor risk, with the p-value being highly significant. Next slide.
So you need to conclude the discussion.
Sure. Next slide. Next slide, please. And this was the efficacy that we saw between the PFS and OS, which I just discussed. Next slide. And if it to look at the intermediate 1 risk to 2 risk, then if it is intermediate 1 risk factor, then again it was akin to the favorable risk in both PFS and overall survival. Next slide, please. This is what we've already discussed. So intermediate 1 was certainly more favorable as compared to intermediate 2. Next slide. So again, the important points to understand is that if it is a favorable risk, it is a very good scenario and sunitinib works very well. If it is intermediate 1 risk factor, sunitinib also works very well, and intermediate group is certainly a heterogeneous group. Next slide. We've discussed that. Next slide. So this heterogeneous group needs to be further evaluated, and further validation can be done or should be done in a randomized controlled trial. Next slide. This also is a real world scenario where the heterogeneity of patients with intermediate risk grouping was seen. Next slide. Yeah, and again, the results show that intermediate risk 1 is better than intermediate risk 2 in both PFS and OS. Next slide. Next slide, please. Very importantly, one has to understand that if we talk about the sarcomatoid features, especially in Checkmate 214, where there were about 60 patients who had sarcomatoid features, these patients, when they were given nivolumab plus ipilimumab, they did much better as compared to sunitinib. So sunitinib is not for patients who have got sarcomatoid features. Very important message that should come across. Next slide. And if we talk about the other trial, which is the Keynote 426, similar thing was seen that if it is sarcomatoid, then sunitinib is not the way to go. Next slide. Again, very importantly, the response to the IO or the IO plus TKI is more in PDL1 positive. So should we really see that PDL1 should be a biomarker before we jump on to using IOs and reserve the sunitinib as an agent for patients who have got PDL1 less than 1 expression? Probably yes. And in times to come, more further segregation of the data and dissection of data for the IO plus TKI trials may tell us this thing. Next slide. Toxicity, as we know, is a driver for many treatment decisions in practical scenario. TKIs, we have got a vast experience. With IOs, there is little. If we talk about the toxicities of TKI, they are kind of prophylactic measures which we can do, and also the incidence and the severity is dose dependent. For IOs, it is not. Next slide. Now we talk about the last 2 minutes about cabozantinib and pazopanib. Cabozantinib is another newer TKI that has come up initially in the first line and now in the second line, which is a VEGF inhibitor. And next slide. We do know that cabozantinib has been pitched against sunitinib in the first line setting in metastatic RCC in a trial called CABOSUN trial. Next slide. These are the NCCN and the ESMO guidelines which recommend that if we have this, we can certainly resort to sunitinib, and if the patient is having an intermediate and a poor risk, then cabozantinib is one of the options for these patients. Next slide. And why this one of the options is given is according to this study that is called the CABOSUN study, where intermediate and poor risk patients were randomized to receive either cabozantinib or sunitinib, with the PFS being the primary endpoint and OS being the secondary endpoint. Next slide. Very importantly, in this trial, both the PFS, which is the primary endpoint, like you can see on the screen right now, 8.6 versus 5.3 months, with a p-value being significantly in favor of cabozantinib. Next slide. And the overall survival, which was the secondary endpoint, again p-value being favorable in favor of cabozantinib over sunitinib, was met. Next slide. That is why cabozantinib adverse events.
Project, can you please wind up, please?
Yes, just 1 minute. Cabozantinib adverse events were just nearly the same. Next slide. So the conclusion is that cabozantinib certainly is one of the options that can be given in as a TKI in patients with intermediate or poor risk stratification. Next slide. Next slide. And this is about the compare study. Next slide. About pazopanib. Pazopanib also is one of the options that can be given. We have this trial where pazopanib was compared with sunitinib as a non-inferiority trial design. Next slide. And it was found out that this trial was Next slide. This trial was a positive trial, and pazopanib was found to be equivalent to sunitinib with a non-inferiority design. So this also is one of the options, specially reserved for patients where the performance status is not that good. So I think this is my last slide. Thank you very much. My important take home is that TKI still is an important armamentarium that we have for patients of first-line metastatic RCC, especially for favorable risk and especially for intermediate risk risk factor 1 patients. Thank you.
Thank you, Dr. Rajat, for detailed insight on use of TKIs in first line, especially favorable or intermediate 1 risk group. And in the era when everyone is talking about IO or IO TKI combinations, I think there is still scope of single agent TKI in this era also. Thank you very much. And our next talk is by Dr. Deepak Shukla, and he is a consultant in medical oncology at Manipal Hospital, Jaipur. He will be speaking on role of nivolumab in metastatic RCC. Over to you, Dr. Deepak.
Thank you so much, sir. And I'll be sharing my slides now. So are slides visible? Is it okay?
Yes, it is visible.
Okay. So at the onset, I'd like to thank Dr. Deepak Gupta for giving me opportunity to speak on this topic and also to BMS. So the topic is an overview of RCC and role of nivolumab in management of RCC. So this is the presentation overview. So I'll begin with the disease overview, which we have discussed mostly in the previous setting. So approximately 90% of the kidney cancers are renal cell carcinomas, which arise in the tubules. The remaining 10% kidney cancers include TCC, Wilms tumor, and renal sarcoma. And from our past experience with the reports of spontaneous tumor regression in absence of treatment, high level of tumor infiltrating T cells, and responses to immunotherapies, prolonged responses, I must say, this is regarded as an immunogenic tumor. So before we go into detail, already this has been discussed that RCC predominantly clear cell, it is divided into clear cell and non-clear cell. So clear cell constitute close to 80%, while the remaining 15 to 20% are non-clear cell histology. The disease again is stage like we do for most other cancers. So coming to the topic in hand, that is the metastatic RCC, and we'll predominantly discuss the second line setting with the nivolumab as a main overview of nivolumab and the second line. So approximately 30% of the RCC patients are diagnosed at a metastatic stage. And also nearly 20 to 30% of the patients who are initially presenting at an organ confined state develop a relapse in form of distant metastasis. And most of them are occurring in the initial 12-month period after the local treatment. And majority of the relapses do occur in the 3-year time line, and the previous survival reported prior to the widespread use of IO was 5-year survival in metastatic disease was close to 12%, and approximately we lose 40% of our patients with RCC to metastasis. So still metastatic RCC, there are a lot of unmet needs. We need to improve the overall survival. We need to improve the durability of the response, improve the safety and the tolerability profile of the available drugs, and to improve the quality of life of the patients when cure is not possible. So just again, why IO drugs have made a tremendous modification or revolution in the treatment of metastatic RCC. So as already mentioned previously, also there has been case report series of spontaneous remissions secondary to immune system in patients with advanced RCC who have not been treated. Also, there is evidence to show that immune cell infiltrates and various immune escape mechanisms are at play in RCC. And previously, prior to the TKI era, the main drugs were interleukin 2 and interferon alpha. And even in at the time of these drugs, there were 5%, 10% patients who went on to have a survival that was well beyond what was accepted. So basically, it was immune response of the body which went on to control the disease. So immuno-oncology drugs is an evolving treatment modality encompassing agents designed to direct harness the patient's own immune system. And basically the all the alterations in the renal cell carcinoma is for the tumor cells to bring about a microenvironment where the cancer cells can hide. So there is a clear rationale for anti-PD-1. There are studies showing that in tumor cells, close to 25% of the clear cell RCC express PD-L1, and the patients who are having PD-L1 expression in tumor cells, there is a correlation with cancer-specific death. The tumor infiltrating lymphocytes are seen to have in more than 50% of the patients have PD-L1 expression. And also the high PD-L1 expression on tumor infiltrating lymphocyte is associated with distant metastatic relapse and poor survival. So this is the last year's NCCN guideline. In possibly in the US and European country where widespread use of first-line IO drugs is very common, possibly the second-line use of immunotherapy, one may argue in that setting. But in Indian setting, when still because of various reasons we are unable to use the first-line IO, nivolumab is one of the options. And also in places where for whatever reason it was not used, possibly due to favorable histology or other reason. So again, this is an option. Also, we have option of cabozantinib. There is an option of nivo-EP. Other recommended regimes like axitinib, everolimus can be used based on the response to prior treatment. And bevacizumab, high-dose interleukin-2, temsirolimus, previously more commonly used, are very rarely used nowadays. So coming to the Checkmate 025 study, this was a randomized open label trial of nivolumab comparing the then standard everolimus in subjects with metastatic clear cell RCC who have received 1 or 2 prior anti-angiogenic treatment, and no patients with CNS mets were allowed. No prior treatment with mTOR inhibitor was allowed, and patients who were taking more than 10 milligram of prednisone for whatever reason were excluded. And there were close to 800 patients, and they were randomized to nivolumab and everolimus. The study endpoints were, the primary endpoint was overall survival, while the secondary endpoint was overall response rate, PFS, adverse event, quality of life, and OS by PD-L1 expression. So if we look into the demographics and baseline characteristics, the majority of the patients were males in the age group of 60 years. Nearly 60% of them were having intermediate and poor risk, and majority have received only 1 prior line of treatment in 75% of the patients, while nearly close to 25% received more than 2 anti-angiogenic treatment. And recently, 2 years back in 2020, the trial's 5-year overall survival was reported. The use of nivolumab led to a 27% reduction in the risk of death as compared to everolimus. The hazard ratio was 0.73. 1 out of 2 patients were alive at 2 years, and 1 out of 4 patients were alive at 5 years in their nivolumab treated arm. If we look into the median overall survival, the median overall survival with nivolumab was close to 26 months. And in the everolimus arm, it was close to 20 months. And still at 5-year time point, nearly 26% patients in the nivo arm were surviving as compared to 18% in the everolimus arm. So if we look into the benefit in terms of OS based on the subgroup analysis, the benefit was seen, which was more in the intermediate poor risk, more in the patients who have received 1 prior anti-angiogenic treatment. And though majority of the patients were less than 75, the patients less than 75 years derived the maximum benefit. If we look into the OS benefit based on the PD-L1 expression, the PD-L1 expression, irrespective whether it was more than 1% or less than 1%, there was benefit with the use of nivolumab. The objective response rate was 23% with the use of nivolumab as compared to 4% with everolimus, with the odds ratio of close to 6.8 favoring nivolumab. And among the patients who responded to nivolumab treatment, close to 28% had ongoing responses at the time of the last reporting 2 years back. If we look into the subgroup analysis in terms of the objective responses across the various subgroup, so almost all subgroup derived benefit in terms of objective response, and also patients who have progressed within less than 6 months of prior TKI or have received or have progressed after 6 months, both benefited with a response rate close to 25%. And what is important with IO drugs, which is the main reason we want to give them, is the duration of responses that we see. So among all the responders, a treatment-free interval without initiating subsequent therapy was experienced in close to 28% patients in the Nivo arm as compared to 6% in the everolimus arm. If we look into the safety profile, fatigue was the most common side effect in both arms. But other than that, except for pruritus, all other side effects were more in the everolimus arm, and the nivolumab drug as such was well tolerated. So looking into the quality of life, when cure is not possible, this is after overall survival, quality of life is the most important concern or parameter which we want to look. So with nivolumab, the quality of life improved over the subsequent follow-up of the trial, while in the everolimus arm, after initial deterioration and also on subsequent follow-up, there was deterioration in the everolimus arm. This Checkmate 25 trial subsequently gave up some data regarding the treatment beyond progression that was published around in 2017. So the patients were in the treatment beyond progression. There were in this subsequent follow-up study, patients treated beyond progression with nivolumab were close to 153, and patients who were not treated beyond progression were 163. So based on the resist progression, subsequently the patient were followed. One group was continued with nivolumab, the other group did not receive nivolumab, went on to receive subsequent other treatment. If we look into the objective response prior to whether the patients continued with nivolumab or were not given, so objective response rate in the population was 20% with in patients who were treated beyond progression, while it was 14% in patients who were not treated beyond progression. And the best overall response prior to this follow-up of nivolumab beyond progression, it was nearly comparable with the slightly more partial responses in the patients who were treated beyond progression. Again, the median time of response was faster in the patients who were treated beyond progression as compared to who were not treated beyond progression. The median duration of response, though, was slightly lower in the patients treated beyond progression as compared to patients who were not treated beyond progression. And looking into the characteristics of patients who were at the time of first progression, so slightly more number of patients were having a good performance status of greater than 90 in who were treated beyond progression, and more patients had improvement at the time of randomization in the treatment beyond progression group. And more number of patients had isolated increase in target lesion in the treatment beyond progression arm. The other site of new lesions were mostly similar. So if we look into the disease characteristics of responses based on the patient, on the patients who responded versus who did not respond or had a stable disease or progress in the tumor diameter, so close to 20%. Already discussed the total out of these patients, 13% had tumor reduction more than 30%. So if we look into the patients who benefited beyond progression with a partial response, so many of these patients were having a good performance status as compared to patients who did not benefited, and more patients with a favorable group went on to get a partial response. And also patients with the most common site of pre-treatment target lesion increase in lung was seen in the treatment with nivolumab beyond progression. So what this trial on subsequent
Deepak, can you please speed up?
Yes, sir, just 2 more slides. So this trial showed that there was improved overall survival with the treatment beyond progression close to 28 months as compared to not treated beyond progression of 15 months. So nearly 50% had some tumor reduction, and majority of them were stable disease, and some of them were partial response, and the safety profile was similar to what we have previously seen. So again, just the summary slide. So Opdata in the second line setting, 1 out of 2 patients were alive at 2 years and 1 out of 4 patients were alive at 5 years. There was improvement in overall response rate, OS of 25.8 months with a response rate of 23%. And there were no new safety signals, and the nivolumab was actually better tolerated as compared to everolimus, and it improved the quality of life of the patients. Thank you.
Thank you, Dr. Deepak. Any questions? Okay. So if there are no questions, we will move to our next session, which is by me, and it is sponsored by Merck. So it will be on RCC, evolution of management of RCC in next millennium. So I'm sharing the slides. So very good evening. My slides are visible now?
Yes, sir.
Okay,
Yeah.
great. So this is the timeline of various treatment which were developed in last 20 years, and we have already discussed in previous sessions also. So our focus will be on this IO space, which has been more developed in last 2-3 years. So these are the few pivotal trials in first line, very limited responses and limited overall survival, as you can see with COMPASS trial, bevacizumab, cabozantinib. These are in first line trials. So oral response rates are 25 to 30 months or 20 months, and median OS was somewhere between 18 to 20 months up to 29 months with sunitinib. So now, when in era of IO, many IO drugs available, so there are various different IO states. One is the IO plus IO, which was tested in CheckMate 214 trial with nivolumab and ipilimumab combination. And another strategy is IO plus TKI. So various trials are available, like Javelin renal 101 trial, which was avelumab plus axitinib as compared to sunitinib. Keynote 426 trial with pembrolizumab plus axitinib versus sunitinib. CheckMate 9ER, nivolumab plus cabozantinib or sunitinib. And Clear trial, lenvatinib plus pembrolizumab. So what's the so it's very difficult because to choose between these various combination. So there are few things which we can learn from this presentation. That one is the separation of curves, Kaplan-Meier curves. So early separation of curves, those who have a large tumor burden and high risk of disease, rapid deterioration, chances of high rapid deterioration, the early separation of curve leads to better their better survival. As you can see in these two trials, CheckMate 214 and Javelin trial. So there is early separation of PFS curves. In Javelin trial with avelumab plus axitinib, it starts separating in less than 2 months. While in CheckMate trial, it starts separating around at 6 months. So right TKI selection is the key in treatment of metastatic RCC along with IO. So there are 3 TKIs which has been studied in trials: axitinib, cabozantinib, and lenvatinib. So axitinib is an ideal TKI to be combined with IO in first-line treatment of metastatic RCC because it is selective and potent VEGF inhibition, less unselected off-target effect which leads to side effect, and longest experience with label dose 5 mg twice a day. So in case of combined toxicity, short half-life of TKI would be better to identify in early management of overlapping toxicities. So shorter half-life supports therapy management, half-life of 2.5 to 6.1 hours only, and reaches a stable level in the blood within 2-3 days of the initial dose. Overlapping toxicities of combination strategies, short half-life TKI is better. So there are 2 overlapping toxicities like diarrhea, hepatitis, thyroid dysfunction, arthritis, and rash. So in case of toxicity, if we stop TKI, so toxicities improves earlier. Time to resolution of grade 3 or more adverse event after temporary interruption or discontinuation of axitinib, treatment by treatment cohort. So you can see that this blue line is for other TKIs, this pink line is for axitinib plus IO, and this purple line is for axitinib monotherapy. in all except this hand-foot syndrome. In all other categories, the toxicities of axitinib monotherapy or axitinib with IO time to resolution is lesser as compared to other TKIs. And it is also a highly specific TKI with a few off-target effect. You can see it affects, it binds to VEGFR 1, 2, and 3, and not to other receptors. So Javelin, which is the main topic, is the Javelin Renal 101 trial, which was the phase 3 trial investigating first-line treatment of avelumab in combination with axitinib versus sunitinib in patient with advanced RCC. So treatment-naive RCC patient with clear cell component, one or more measurable lesion with tumor tissue available for PD-L1 testing. They were stratified as per ECOG performance status and geographic region. And there were more than 800 patients randomized to avelumab plus axitinib versus sunitinib. Primary endpoint PFS and OS, key secondary endpoint PFS and OS in overall population. And there were additional secondary endpoints also, like overall response rate, time to response, and duration of response. So it has avelumab plus axitinib has significantly improved PFS, with OS still not reached in advanced RCC. As per PFS central review, it was 13.3 months versus 8 months with sunitinib. So there is 31% reduction in risk of disease progression with avelumab plus axitinib, and 5.3 month improvement in PFS. Overall survival is still not mature, but curves start separating early. So PFS2 in combination, avelumab in combination with axitinib demonstrated greater PFS2 in overall population versus sunitinib. It was 19.4 months with sunitinib versus not estimable with avelumab plus axitinib. So 45% reduction in risk of disease progression or death for PFS2. As far as tumor shrinkage is concerned, this waterfall plot shows that most of the patient had deeper responses. 52% had confirmed overall response rates as compared to 27.3% with sunitinib. And median time to response with avelumab was 2.7 months as compared to 4 months with sunitinib. Treatment-related adverse event, more or less, these treatment-related adverse events are comparable or even lesser with combination. So avelumab and axitinib, it is longer median PFS in 31% reduction in overall population, nearly 2 times objective response rates, lower discontinuation rate, consistent PFS benefit across subgroups based on PD-L1 status and all prognostic risk groups, faster median time to response, and lesser higher dose corticosteroid use in avelumab arm. So if we compare overall survival across various trials, so upper two curves are for avelumab, axitinib, or pembrolizumab and axitinib, which have got highest survival, overall survival. Middle curves are for nivo-ipi combination, or these lower 3 curves are for sunitinib in various trials. So sunitinib has lowest survival, overall survival as compared to IO TKI combination. So safety of doublet arm, benefit profile, better profile with avelumab plus axitinib. You can see that this grade 3, any treatment related adverse event leading to discontinuation is only 3.5% with avelumab plus axitinib, and pneumonitis rate is also very low, 0.63, and dose reduction is 42.2% as compared to 56% with nivo-cabo and 67% with pembrolizumab. So it is the one combination which shows consistent efficacy in every risk group. Like in this Javelin trial, you can see that in oral survival and PFS, in both favorable, intermediate, and poor risk categories, their hazard ratio is in favor of avelumab plus axitinib. PFS also, the hazard ratios are in favor of avelumab combination. Overall response rates are also very high, while in other trials, they are more effective for intermediate and poor risk as compared to favorable risk group. Quality of life important before selecting any combination therapy. So dose reduction is like you can see the pembro plus lenvatinib 68%, nivo-cabo 56%, and pembro axitinib 20% dose reduction were seen because of toxicities. So treatment approaches for progressive RCC after 1 or more previous lines of therapy. So these are the second line treatment for advanced or metastatic RCC, like nivolumab immunotherapy based regimens which have IO or IO plus TKI combination. Then TKI based therapies like cabozantinib, lenvatinib plus everolimus, axitinib, everolimus, and other selected treatment like bevacizumab, interleukin 2, and temsirolimus. So post TKI therapy in pivotal randomized trial in clear cell RCC, post TKI cabozantinib versus everolimus, nivolumab plus versus everolimus, and lenvatinib plus everolimus versus everolimus. So these are the phase 2 trials, and overall response rates are around on the tunes of 20%, and with lenvatinib and everolimus it is 43%, which is the highest in second line, and median OS is in around 2 years after first line failure. Selecting salvage therapy for patient with high volume and rapidly progressive disease on a previous VEGF therapy. So cabozantinib median PFS is 7.4 months as compared to 3.8 months with everolimus. Lenvatinib plus everolimus had got a very high PFS of 14.6 months as compared to 5 or 7 months with single agent, and nivolumab 4.6 months versus 4.4 months. So cabozantinib or lenvatinib plus everolimus is can be reserved for second line or third line treatment options. So there is no clear advantage of any combination over other factors to consider in choosing combination, like treatment goals, toxicity profile, frequency of infusions, half-life of TKI, efficacy versus safety, and which options are available for second line post progression. So with this, I will conclude my talk. Thank you for your patience listening. I think we are running late, so I think we should move on to panel discussion now. I will invite Dr. Amit Rothan, who is HOD and Consultant Medical Oncology at Manipal Hospital, Bengaluru, and he will moderate the panel discussion. Good evening, Dr. Amit, and welcome.
Hi, good evening.
The stage is yours now. Please invite your panelists and.
Right. Thank you. Good evening. Thank you for having me. So I think, let me invite the panelists. Dr. Chandrakant is there? No, I don't see him.
Sir, no, he's not there.
Okay, so then Dr. Deepak is
Okay,
here.
I am here.
Yeah, so I think Dr. Deepak Shukla, Dr. Deepak Gupta, both of us are here. And Dr. Varun is here, so that's good. Perfect. I think so. What I'll do is I'll quickly start sharing my slides. Okay, so we've heard the talks, we've heard about all the data sets. What I'll do is quickly, how do we apply it in clinical practice? And we'll take it from there. So this is a patient who presented to us some years back, 60-year-old male with cough and breathlessness, very breathless actually. And CT thorax showed extensive lung metastasis. PET scan was done, which showed RCC of the left kidney with lung and bone metastasis. Biopsy showed clear cell RCC. And this is the patient's scan, if you see. That's how bad it was. It was the massive left kidney mass. Look at the lung metastasis. There was hardly any lung. His ECOG was 2. He was oxygen dependent. He also had anemia and high WBC counts. He comes into a high risk of IMDC. So our first question is, I wanted to discuss about the staging, I mean the risk categorization. So what do you do in clinical practice every time when you see a patient? So let's start off, Dr. Deepak Gupta.
Yes, Dr. Amit.
Yeah. So how commonly are you comfortable using the IMDC, or do you sometimes use the MSKCC?
No, I use IMDC only most of the time.
Right. Okay. And it's IMDC for everyone, and it's a very easy calculation for us.
Yeah.
Right. So I think all of us are very happy with this. So suppose you have a patient like this. Let me come to Dr. Deepak. Shukla, if you have a patient like this who's coming to you with this kind of a lung and this, what are you thinking of in your mind?
So, sir, we have confirmed it with tissue diagnosis when we are saying that it is clear cell RCC, because again, this is a very aggressive presentation for RCC. Means I have uncommonly seen it, but seeing this picture in a metastatic RCC, my key goals would be to rapidly reduce the disease. So whatever I am choosing is for response rate, sir.
Right. So I agree with you. Actually, this is not something we routinely see in RCC in our patients. But I kind of remember over years, I have seen a group of patients who come like this and who earlier used to just deteriorate off, and they would be gone in some months. That's how it used to be in our practice earlier. So this is a very interesting case because of that reason. So as Deepak mentioned, we always do IMDC. Sometimes I don't agree with these curves which we show on the right side, because this is the TKI era curve, and now the curves would have changed definitely, especially because we are talking of immuno, and all the high risk are mostly sarcomatoid, and those curves will really jump up. So that's the reason why we say they'll probably change a lot, and there's going to be a new publication very soon of the immuno era where they're going to change the data sets of survival and show us what's the OS with the new IMDC stratification. So that's what we are all waiting for. So again, now Deepak did show us all those decisions of IO, and then the IO TKI talk where we heard about all the pros and cons. So Varun, how are you thinking about in practice these days when you think about IO and IO TKI? Where are you placing it in your practice? I think you're on mute.
Hello?
Yes.
Am I audible?
Yes, you're audible. Faint, a little bit faint, but audible.
So, first of all, as Dr. Deepak Shukla has already told, that in this type of high burden disease, we need fast response first. So, in any case, I will use TKI if alone or otherwise with combination of IO. So that depends on IMDC risk stratification. If patient is in good risk, this patient is not looking like in good risk, but still, if patient is in good risk, then only TKI. Otherwise, intermediate poor risk, TKI plus IO for this type of presentation.
Right. So this kind of presentation, you are clearly saying IO and TKI. Right. Dr. Deepak Gupta.
Yeah.
So
I will in this patient with so high volume of disease and poor performance status, needs rapid response. So I think IO plus TKI combination would be the choice. And if you ask about this combination, then I would go for pembro plus lenvatinib, which has got highest, I think, response rates.
So you are favoring pembro lenvatinib as your regime nowadays. That's the way you're going. Right. Okay. Kind of we have all, at least we all started with pembro axitinib a few years back, and now we are changed very rapidly.
Yes.
I think that's one thing we have seen, the responses and the way the curves have changed. Even all of us have moved to lenvatinib based combinations, or even cabozantinib based combinations. Even that is a pretty good regime. And that's, I think
cabozantinib also, yeah. Yes.
Correct. I think all of us kind of agree axitinib may be a little inferior TKI. It is less toxic, definitely, but it is a little inferior TKI. I think this IO, Deepak, you mentioned about this in your talk. What patients will you select the IO combination in practice per se?
So I think those patients who are favorable or intermediate risk or even poor risk, but don't have disease burden, much disease burden, and those who don't want to take the toxicity of these TKIs. So these are the candidates for this IO therapy. And I think there is some chances of maintaining good, especially one important thing about this combination is CR rates. So these high CR rates and even maintaining drug-free interval also is possible with these combination.
Right. I think a couple of points there. One is the CR rate is 11 to 12%, we used to call it high CR before the pembrol lenvatinib data came out. Now
Yeah.
the pembrol lenvatinib costs 17% CR. So our thoughts are suddenly that, oh, we can get good CR even with pembrol lenvatinib. But I definitely agree with you. Anyone who doesn't want a TKI toxicity, and that's one thing which makes sense. And secondly, you may have sometimes limited treatment. Somewhere you can stop. That's what you keep thinking in your patients. Pembrol lenvatinib trials stopped at 2 years, though the Nivo trials don't stop, but pembrol trials were all 2 years trials. So it kind of is an exciting thought that maybe you can treat for some time and then you can stop. Any experience, Deepak Shukla, about IO? Have you used it in clinical practice, and what have been your experiences?
So, sir, I have recently used in a patient who actually, when he came to me, he came after nephrectomy. He was diagnosed when he was having weakness. Somehow at the baseline staging PET, he had brain mets at that time. So he was a 50-year male patient, intermediate risk with brain mets. So in that patient, I have now given Nivo EP 4 cycle he has completed. In fact, first cycle maintenance nivolumab. And his first response is a partial response. And in spite of using it with steroids for brain mets, now after 3 to 4 months, all the steroids have been stopped. He came on a wheelchair. Now he is able to walk. So he means that is the one experience I'm having with Nivo EP.
Right. So that's an excellent response. When you're talking of brain mets responding, did you, by any chance, out of curiosity, did you radiate the brain?
Yes, sir. On means prior to starting any treatment, I did irradiation, and then I started after radiation. I started with Nivo EP.
Right. No, that's the way we can see sometimes responses can be tremendously good, and the main thing is they may last very long, and that's what we are all seeing in practice. So that's really very the promise of IO, which we keep talking about. But I think even the IO TKI is now starting to show durable responses. We have seen the pembrolizumab data now for 4-year follow-up. So even we have long-term follow-up for that. So I think very all of you have shown that in all your trials, and we've seen that clear sustained response is what we are looking for, high response rates and maybe even CR. So our patient, this is sometime in, I think this patient came to us in February 2020. That's a couple of years back. He got IO-TKI, and this is what happened. And within 1 month, he was off oxygen. Within 2 months, everything disappeared, and he did remarkably well. And his quality of life improved. He became tremendously. He became almost like a fit person, So we kept doing PET scans, and we saw the lung got better and better. And we came to a time where the lung did not pick up anything in the PET. So this is how immuno-TKIs can work in our patients, and that's why we don't give up on any RCC patient nowadays. Earlier, it used to be that these patients would have ended up with palliative care sometimes. So my question, Dr. Varun, if you have a patient who responds like this, now comes to you, what is your role of cytoreductive nephrectomy? It was not done earlier. Would you want to address surgery in this patient?
No, I don't think any role now. Like already patient have responded very well at metastatic site. So most likely renal mass also have been responded. So what's the need now? I don't think there is role.
Right. I think these are very controversial questions. What are your thoughts, Deepak?
I also don't prefer if patient is responding so well and there is no symptoms because of that renal mass, hematuria, pain or something, then I would not prefer nephrectomy.
Okay. So any patient you are doing cytoreductive nephrectomy, if they are in any group patients, if they are, even if they are not
maybe sometimes if upfront sometime patient get nephrectomy, maybe they can get it done other centers, then come to us. But after starting treatment, if patient is responding well, then I don't go for this cytoreductive nephrectomy.
Right.
Okay. If during treatment, if we are going for nephrectomy, that maybe it is palliative nephrectomy in view of symptoms. Otherwise, what is the need?
No. So I think we can do
cytoreductive nephrectomy if more tumor burden is in renal, like kidney mass is big, but metastatic sites are small or less in number, not symptomatic.
Minimal metastatic burden, yes.
So possibly in favorable risk group, favorable risk group, one may discuss when the biology as such is slow. But again, most of the time these patients come after nephrectomy to medical oncologists. So,
right. No, I think all of you have brought out very points which we discuss a lot and deliberate a lot in meetings. So in the TKI era, we always said some nephrectomy is good. And it always, at least we believed it added in survival, even if the patients were asymptomatic. And that's what we are not able to answer in the immuno era. And that is what is creating a lot of confusion.
But,
So what we
just-
do is exactly what you have mentioned, Deepak Shukla. What we do is we say, if my patient was favorable risk and I treated and they did very well, if for any reason I used IOTKI also, I still am sending them for cytoreductive nephrectomy after a good response, still believing maybe because of the long survival, there may be an advantage. But if a patient is high risk like this patient, I kind of deliberate with the patient. Maybe we don't have any data saying it will benefit, but we still have some old data saying there may be some benefit. So it's very controversial. There's a clinical trial now looking at it in a proper fashion where they're giving immunotherapy, looking at responses, and then doing a randomization between nephrectomy versus no nephrectomy. So I think that trial will be the first time we will answer this question in a proper manner, whether to do it or not. So very controversial, and I agree with all of your thoughts. So incidentally, this patient I sent for nephrectomy, and we did a nephrectomy after 1 year because there was no disease anywhere else. But this was a high risk patient, and we ended up doing one. Now, so the other points of discussion, I think Varun mentioned this. How would you treat your favorable risk patients presently?
So favorable risk patient we usually treat with TKI alone. So
TKI alone? And which TKI?
So I have all three options like sunitinib, pazopanib, and cabozantinib now. So if PS is poor, then in that case pazopanib. Otherwise, sunitinib or cabozantinib. With cabozantinib, my experience till now is not so good because any of my patient haven't tolerated 60 mg. Like 40 mg is okay, but 60 mg patient doesn't tolerate. With sunitinib, I have rich experience. So still, my preference will be sunitinib to start with.
Right. So Cabo becomes very controversial because they did not usually use favorable risk in their trial. So their first line trial was only for intermediate and high risk patients. So whenever we try to extrapolate data from favorable, all of us, I don't think we are doing wrong. I think we are doing justice saying we are doing something better, but we don't have data about it. So it always becomes an issue. But I agree with you fully. Favorable risk is one place where we still say TKI has a role. But Deepak, do you do favorable risk patients? Which patients would you want to give an IO to? Oh, okay.
You're asking
Deepak.
me?
Yeah.
Okay.
I will have
no,
to
actually, most of the time it is TKI only, and that is most of the time sunitinib actually, and which is because we are very much used to use sunitinib. And some patients, as I already told you, that if someone wants to have some CRs or someone wants to avoid this TKI, then we can use some IO combination also.
Right. Yeah. So favorable risk, IO, I think in the long term is going to become useful. But as of now, at least IO in the favorable risk is a very controversial thing because of the way the survival curves are coming out. But definitely there are higher CRs and probably those will extend the survival. But IO-TKI can definitely be an option for your favorable risk patients. So we in our practice say that even if our favorable patients who have a very high burden of disease, sometimes we do get that patient, burden is high, but they still sit in the favorable risk. We definitely talk about IO-TKI to those group of patients, and that's the way we keep thinking about. Right. Dr. Deepak Shukla, do you do any biomarker testing in any of your patients, PD-L1 or any other biomarkers you think are important?
Sir, so just a point in the previous discussion. So possibly in a patient who is having low ejection fraction or cardiac issues, in that setting when we cannot use TKI, possibly a combination of IO with an IO can be used. So suppose a patient with ejection fraction of 25% means I have used in one of my patient. So that is an option. And routinely, I am not using any biomarker in RCC.
Right. Points well taken. I think cardiac toxicity with TKI, if there is and you want to avoid a TKI completely, point well taken. An IO can be considered. Though in the EP-Nivo, when it came out, especially in the melanoma data, we had seen that rare cardiomyopathy and cardiac mortality. So that's something that we keep getting scared about in the back of the minds, but I think it's something we don't see this in our data sets where the dose is lesser. We do 1-3, so it's quite easy and comfortable for most patients, right? Biomarkers, no role of PDL1, we don't do it. None of us do it. That's, I think I would fully agree. Dr. Varun, how long do you give immunotherapy is in your practice?
So, as such, by recommendation, if we go, so this should be continued till progression or unacceptable toxicity or financial toxicity. So, but in one or two of my patients, I have stopped at 2 years because patient was in metabolic CR and he was fine. So I have stopped, but otherwise to continue.
Right. So the data for Pembro trials are all 2 years. So there it's 2 years. Nivo trials do indefinite. They don't do 2 years, and that's the difference a little bit from the Nivo trials. We have looked at our patient population of patients who got CR, and we have actually stopped much earlier in many patients. So we have a pool of patients where all patients who got CR, we do scans at repeatedly. If they are doing well, we stop at 1 year. And we have a good data set there, and that's been our personal experience. I think this was a very...
Just a question.
Yes.
Do you increase the duration of Nivo? Means suppose from 14 to 1 month in...
Yes. So we do it a lot. We do it a lot.
This can be done.
Yes. So after 6 months or so, we do it a lot, and that's been our practice.
But in that case, like we have to increase the dose to doubled. So just logistic issues covered.
So that is the ideal way of what you're telling of what the recommendation from the guidelines are and from what the US all the registries are, and that's how the trials were done. I am talking of practically what I feel is we give a lot of immuno, which maybe the dose may not be required for many patients. So what we do in our patients is after we've got 3 months, we're doing very well. We do 6 months, we're doing very well. We actually wrote about this and we sent a paper to ASCO also, where we said after 6 months, if your patients are holding very well, you can phase it out. You really don't need that 2 weeks. And even if you're doing 3 weeks, you don't need to keep hiking the dose. You can go to 4 weeks and then slowly phase it out and then stop it. And we stop off in a year in most patients. And we believe we do a lot of immuno more than what is required, but that's the way the study has been done. So we can't deny it. It is more of financial reasons for our patients that we keep doing a lot of various things, and it becomes justifiable for our patients. But I agree fully, as per trials and as per data sets, and how it is you should increase the dose if you're increasing the duration. So this was very interesting, and I wanted to just put this up. Biomarkers, PDL1 is very prognostic, and we have seen this from the TKI era. Anyone who has a high PDL1 will actually have a poorer survival from the TKI era. So that's been seen. But now we know if high PDL1 will probably be a better response to immuno, but we know low PDL1 will also respond. So PDL1 is interesting, but again, it's not something that we can use in clinical practice. Otherwise, we will miss our patients. TMB again is very controversial, no major role. PBRM is very interesting again, but again, controversial, not for clinical practice. We've looked at NLR, and this is something that we keep saying everyone can do in the RCC, just look at the neutrophil lymphocyte ratio, and NLR of many people have used 3, some have used 4, some have used 5, but around 4 is what we believe. If you see an LLR is going up, very easy to do, you may actually predict a response to immunotherapy. So if your lymphocytes are going up, your patients will have a better chance of responding. And there are various ways people are looking at this. And again, this is something that is our own. We have our own data sets where we looked at all our patients with immuno, where looking at NLR is a very easy way of trying to even choose patients sometimes. So my belief is if you have an NLR which is very low, probably single agent immuno is not going to work very well. So if you get high neutrophils and low lymphocytes, but if you have a very high NLR, sometimes even a single agent IO drug may work, and whether you need a combination or not. So it's very intriguing. People are looking at it in very different ways. But yes, the problem is you can't use it for clinical decision making as of now. So I would encourage everyone to just watch your NLRs when you give your patients immuno, especially in RCC, though there is data from all the other cancers also. So how do you manage progression? I think we saw the slides. If first line TKI, I think very straightforward anyway. I think what we'll do is we'll quickly just run through this way. Yeah, I think this is the best way to do it. If you give first line TKI, I think everyone receives immuno, right? Or do you think of? Absolutely. So second is, if you got an IO based doublet of IO TKI, what would you do? And that's the whole controversy now. What do you do nowadays if you got IO-TKI progression? Let me start with each one of you. Dr. Deepak Shukla, you?
So, sir, again, we have already used IO-TKI. So, means I'm assuming that patient responded well, or did we have a treatment-free interval?
Okay, yeah, sorry, I didn't tell you this. So maybe let's put two scenarios: one patient who did well for a year and then progressed, and one patient progresses in 3 months.
So the person who progressed with the means initial upfront itself 3 months, then definitely any other combination, possibly lenvatinib with everolimus is an option.
And what if you had used pembrolizumab in the first line?
If we have used pembrolizumab, then again exitinib is one of the options. But again, I'll be more comfortable with everolimus in that case, possibly a different pathway, mTOR inhibition.
Right. Okay. Dr. Varun, if you had a patient who gets IO-TKI first line, progresses quickly or late?
So same, like if quickly, then this lenvatinib plus mTOR inhibitor. Otherwise, if late, if patient progress even after 1 year, then we can even re-challenge the same combination. Like we have started the treatment IO-TKI, patient responded, we have discontinued IO, and maybe TKI have been continued. Maybe after maybe gap of 9 months, 1 year, if patient progress, then we may re-challenge with IO, but this is very rare scenario. So if we have started IO-TKI early progression, we should change to len plus mTOR. Otherwise, any other TKI.
Okay.
And there is, sir, just some more data for if a patient has responded to a single agent IO, possibly Nivo in that case. So there is some data from Titanic that we can add ipilimumab on progression. So
correct. That's also another interesting. Dr. Deepak, your thoughts if you treated pembrolizumab in the first line, because that's the highest response rate. There's no doubt about it. All of us are tempted for that as first line. Then what do you do?
Yeah, so I think then option remains single agent TKI like sunitinib or maybe cabozantinib.
Okay. So cabo is definitely something that we can go for, and it becomes a little difficult, that's the whole dilemma nowadays, when we keep thinking we are doing the best upfront, and when we do upfront it doesn't work, and then we start talking of going backwards to axitinib, it becomes quite dilemmatic even in our minds. Will it work really, axitinib, when we start thinking of that, or when you're going back to one of the preliminary drugs? I think rapid progressors will not respond to most of these older generation.
Most of these drugs, yes.
Correct. I think cabozantinib may be the only way. I struggle with this decision. I like cabo nivo as my first line option for this reason, that at least lenvatinib everolimus is available for me as second line.
Yes, that's also because len plus everolimus has got very good role in second line.
Absolutely.
And it's a very good response also, means patient tolerates also very well. If you reduce the doses of lenvatinib little bit, and it's a very good combination.
Right. I fully agree with you, and all of us have very good experience. So cabo came very late, and last few years we have been using lenvatinib everolimus, and all of us have seen very good success stories. So that is a struggle. I wish there was a different kind of a cabo everolimus trial which had answered that we can use that combination. Then it becomes easy for us to switch to that. But till now, cabo is only single agent in progression, so that's a dilemma always. So I think we have covered this, and this was covered in all the talks. So this was one patient of ours where I wanted to show what happens when you do IO-TKI first. We did IO-TKI, patient did very well for 1 year, progressed. When progressed, we got Nivo EP as per what you shared, and we gave 4 cycles of Nivo EP. He progressed. And in 3 months, he progressed. The next scan, it was progression. So till now, all my second line Nivo EP patients have progressed very rapidly. I have not had much responses, especially those who have responded to IO a long time. Adding EP, I am not very encouraged by. Only very few patients may respond. Most may not respond. So then we went to lenvatinib everolimus, and he responded very nicely, and he's doing very well. But toxicity is a major concern. I think all of you would be experiencing that. What is the dose of lenvatinib everolimus you use in practice, Varun?
So we usually use len 10 mg and everolimus 2.5 to start with. and try to go by 5 mg if possible. Otherwise, most of the time 10 and 2.5.
Okay. That's quite a low dose. So
yeah, I usually use 16 mg len and 5 mg everolimus.
Right. I think that's the way most
Yeah.
of the people do. I use 14/5 is what I do, and then titrate it up or down. There's only a couple of patients where I've been able to give the ideal 18/5. Others, everyone has been either in 14 or and 10. So incidentally, there has been a study which they looked at the dosing of lenvatinib in these combinations, and they said that if you dose lenvatinib less, your responses are less. So you have to dose them high. But it's not a reality. We can't dose them at that dose what they keep recommending. So that study actually said if you dose even 14 and not 18, you're doing an inferior survival. They said clearly your survival is lesser. So they said somehow you should start with 18, but it's impossible. The patients get so sick with 18. So I kind of think 10 to 14 is fine with us. Everolimus doesn't need too much of dose reductions in this group of patients. They do really well. So lastly, I will just show you our data. This is our last year's ASCO presentation, first line IO-TKI combination from our center. We had 22 patients with IO-TKI, 12 had received combination with axitinib, and then we shifted to lenvatinib. So 10 were on lenvatinib. We had 13% were favorable, 59 intermediate, and 27 were poor risk. We had CRs of 9%, we had PRs of 59%, 68% overall response rates. We had 3 patients who had toxicities where colitis, pneumonitis, we even had an encephalitis, and all these 3 patients, we had to stop the IO permanently. TKI toxicity definitely is manageable by dose reduction, so that's never been a problem. But this is a response we got, and that's the reason why we are very encouraged. 70% response rate is exactly what you saw from the trial, exactly almost the same response rates. And this is our PFS, and we've also got a PFS of 22 months in at least this small group of 22 patients. Even the OS at 1 year is very good. So we are also kind of saying these combinations clearly, even for our patients, are very effective, and all of us see that in practice now. So I think IO-based combinations are here to stay. It's all about using more and more and getting used to the toxicity management. So I think with this I will conclude. IO or IO-TKI, one of them is the way forward. Except the favorable risk where TKI alone is still the way forward for most of our patients. Second line is getting tougher and tougher, and decision making of second line is more intriguing. Two ways I think the problem comes. The problem comes is you spend such a huge amount in the first line, and then if you don't get response, patients hold you responsible that you're not responding after spending that much money. So it becomes very, very difficult to explain to patients. But definitely we are improving survival of our patients tremendously, and there's really no doubt about it. So thank you very much.
Yeah, it's a wonderful data by your center also, Dr. Amit. Congratulations to you for that. And it was really very good discussion on first and second line treatment of metastatic RCC. We had discussed TKIs, IOs, combinations and all. So I think with this, we conclude our meeting today. And I would thank all the presenters, Dr. Asim Samar, Dr. Rajat Bajaj, Dr. Deepak Shukla, Dr. Amit, Dr. Varun, and Dr. Chandrakant could not join. And thank you, Tarunji and Horizon Conference for organizing this meeting so successfully. I thank you all again for sparing your valuable time today, and keep looking forward to see you again in near future.
Thank you. So thank you, Dr. Deepak Gupta, sir, for moderating the entire session. And thank you all the faculties. So from all of us, from the organizing team, my colleagues, Surbi and everyone, we wish you stay safe, stay blessed, have a nice weekend. Until then, thank you and bye-bye.
Thank you.
Bye-bye. Good night, everyone.
Bye.
Thank you.